All right. Hello, everyone. We're going to go ahead and get started now. Welcome to another session of Virtual Global Spine Conference. It's a pleasure for me to be hosting today as well as speaking. So we thought this would be a great topic to discuss with everyone today. It's a topic that many of us are quite passionate about. We know we've had several of these presentations here on virtual spine. As everybody knows, we really are big on innovative technology, new radiology, spine surgical techniques. So the topics of robotics, navigation, and minimally invasive spine surgery come up quite a bit. So I'm excited to welcome everybody here today, and I want to share with you some of my thoughts on this topic. So these are my my disclosures, which should not have any really meaningful impact here. Let's talk about the more important disclosure, however, though. So the first thing that that I would say is, my very first robotic case here, we're probably about 25 or so cases into it, I had a spinal fluid leak. So I'm not here in any way, shape, or form to preach that this is the best solution, this is it, we have to use this all the time. But like anything, there are challenges that come up with new technology. But I will say I am a firm believer, however, that I do think it is the future. I think advanced navigation, robotics technology in different iterations, probably not the same iteration that we're seeing today, is definitely the future. So my advice, at least to most people, is at least, let's embrace it, let's improve it, let's make it better for us, for our patients, but also for future generations. There's no question that the type of navigation systems that we're using, type of robotic systems that we're using, is going to change with time. So what you're seeing today is not what's going to be certainly in the operating room 20 years from now, or at least I hope not. My personal journey with navigation began probably towards the end of my training, my neurosurgical residency in Tampa, Florida. These publications happened a couple of years later, but towards the end of my training, where we first acquired the O-arm, actually, the image acquisition system, as well as navigation, and we're very excited about it. We published on this years ago, and really from then on, it really started my personal journey. So I'm not necessarily new at this, although certainly with the robotics platform, we're just exploring those now. But we've had the pleasure of playing around a little bit with the navigation systems from years ago. This is how certainly I was doing these early on, as probably many are or perhaps are currently doing this. X-ray, a lot of it is X-ray based, fluoroscopy based. I like MIST lifts, I like percutaneous screws, and I was doing them always under X-ray. And it works just fine. It works just great. Only issue with it is you do have to wear lead. There's probably a lot more ionizing radiation to both you as well as the staff, in addition to the patients. So, the technology has been changing, improvements have been made. And then we went from, or I personally went from this to, as of a few years ago, this all-in-one percutaneous screw system, which everybody knows I like very much. Doesn't matter what company or brand it is. There are several of them in the market that are excellent. But this is really CT guided navigation now. This is, not wearing lead, not using fluoroscopy, and getting the spin, whether it's an Arrow or an O-arm or a Zeem, which I like all those technologies. And then, the machine comes out of the way, and you're placing the instrumentation. So I do think that, it was a big step, at least for a lot of people, including for myself, going from X-ray or fluoroscopy based to CT guided navigation. And now, of course, we're playing with these different surgical robotic technologies. Currently, the one we have or we acquired is the BrainLab Circ, and we're hoping to expand into and explore other platforms. So the question is can we take that case that we were doing in a minimally invasive fashion under fluoroscopy, next step was CT guided navigation, but still a lot of manual dexterity involved. You have to put in the screws yourself. You have to do it, really everything yourself, but under guidance. Can the robotic technology take you to that next step? Can it take you to the next step of accuracy, precision, and automate some of those steps? So that's what we're going to be talking about today. I've shown this slide before. This is an older slide, actually, of a survey that was done over 10 years ago at one of the Smiths meetings, and the two most common or the two biggest reasons why folks and surgeons just did not want or felt that there were primary barriers to adoption of minimally invasive techniques was both radiation exposure and the expense. And I would say up until very recently, that really is the case, and that has not changed all that much. There's still, as far as fluoroscopy is concerned, radiation exposure is still a big factor. And certainly as you bring in CT-guided navigation or robotics technology, there's still a lot of radiation exposure. It's just now to the patient, not to the staff. And we can have a whole different conversation about that. But certainly the expense is still there. So I think we have an obligation to make some headway in this space. I think the radiation exposure is a very, very real issue with minimally invasive spine surgery. And that for a long time, that has been a deterrent for surgeons and trainees to pick up this technology. And, the title of the talk is, how is navigation, how's robotics redefining MIS? I think that's probably the number one category. The number one area is it is decreasing the radiation exposure to the surgeon, to the staff, and obviously that has huge impact if you compile the number of cases one can do over a lifetime. So I think that alone is an absolutely excellent way that, in my opinion, it's already being redefined. So, if we spend a few minutes here on minimally invasive spine surgery, we know what these are, right? These are MIS T-lifts, these are laterals, O-lifts, X-lifts, D-lifts, percutaneous instrumentation. We don't have to rehash the benefit of them. We know what they are, right? We know that there's less blood loss, less infection, probably no difference in long-term outcomes. We know that, but at least for the short-term outcomes, they seem to be quite superior. So where does robotics and navigation come into play? How does robotics and navigation affect this? The truth is when it comes to minimally invasive spine surgery, it really comes into play probably in one area and one area only, which is it does increase the accuracy and the precision of instrumentation. That we know. What is a little bit concerning is that obviously currently the technology doesn't do much more than that, and that's something that I'll talk about at the end. But it's what I call Nav Plus. We want robots and we want navigation to help us with the decompressions, with the osteotomies, with the corpectomies, with planning, with rod contouring. Right now, it's really good at placing screws, not much else. But that's I think about to change, and we know that is the future. So as far as ionizing radiation, again, we know that's a big factor, and we know the effects of repetitive dosage and repetitive fluoroscopy, especially in these multi-level MIS cases. Percutaneous screws, multi-level laterals, it's tremendous. It's a lot of radiation. And we know that robotics and navigation, again, does have a role in that. And a lot of the folks who advocate for open freehand surgery, you know, and we still do quite a bit of that here. I give it to those surgeons because they're right. With traditional freehand technique, you're utilizing less fluoroscopy, less radiation, which is very, very important. So, you know, I tell folks that, in my opinion, navigation, image guided assistance, robotic technology is probably most helpful in minimally invasive spine surgery. For the open surgery, I use it a lot. I think it helps me as a traditionally freehand surgeon. It helps me become more efficient and faster in surgery. But I think there's probably equipoise there. Whereas with minimally invasive spine, that's really where that technology could be leveraged in terms of accuracy, radiation exposure. And these are just some studies that highlight that in terms of certainly the radiation exposure in minimally invasive spine surgery. This is a well-established topic. This is something that's not new. And I do think that the conversation is necessary. It's necessary. It has to be ongoing because we have not solved that problem yet. We have not solved that issue yet for minimally invasive spine surgery. How about the accuracy? We alluded to that earlier. Well, here's the full story, right? Let's all be on. I promised this would be a very honest assessment of this technology, so we have to keep it that way. We know that published reports of freehand screws versus fluoroscopy versus navigation versus robotic. You all can look at that. We have some, you know, we have some studies here that I'll show in a minute, but we know what the literature shows. The accuracy rate is high. The accuracy rate is high in all of those approaches. Yes, radiographically, navigated screws, robotic assisted screws probably are more accurate, more precise. But in terms of clinical outcomes, in terms of neurological issues, revision cases for misplacing instrumentation, it's probably not that different. The difference is actually small, and this is something that we need to consider. Again, I quote unquote grew up doing freehand screws, and I enjoyed it. And this is one of our published reports from years ago by our outstanding residents from the University of Arizona. 96% accuracy rate, 96% accuracy rate, open freehand. But these are open cases. These are not MIS cases. And that's where I'm saying, and that's where I'm advocating for leveraging this technology primarily in minimally invasive spine cases. You know, I don't, this is not meant to scare people. You know, nobody likes to talk about these, but I actually just did this morning. This morning, as I was preparing for this talk, I said, let me inject some medical legal issues here. So I literally this morning Googled this lawsuit, spine surgery, misplaced screws, and this is the first thing that came up. 8 million results. You know, from I guess Ross Feller Casey. You know, I don't know this law firm, but this is the first thing that you see here. That, you know, as far as medical legal issues and whatnot. And then, of course, you look at medical legal impact. This is a nice review article here in JNS Spine. The number one cause was basically misplaced lumbar pedicle screws. Lumbar pedicle screws were one of the highest, and the number one cause in this review for medical legal action, with average payouts over $1 million. So. You know, so this is a serious thing. Now, again, nobody wants to practice defensive medicine, and we should not. But the reality is, and I'm going to say this very slowly, so everybody like hears this. The reality is there is less of an appetite for revision surgery for misplaced screws, less of an appetite for issues related to misplaced hardware. Back in the day, and I know a lot of people here on line, I see everybody's names here. I know a lot of people here, and I know a lot of them will agree with me. You know, it used to be where you take somebody to surgery, you do a TLIF or you do a Scoli surgery. You know, you don't even get a CT post-op, right? But if you did, or you got an X-ray, it looked funny, you get a CT, you know, it looks like the screw does not look great. Well, you take the patient back, you change it out because you just don't want that patient to have that screw, very medial. Perhaps it's causing pain. I would say in a lot of places, that was just part of the business. That was just the cost of doing business, if you will. These days, in a lot of medical centers and a lot of institutions, at least in the United States, I'd be interested to hear what our colleagues from around other countries think. There's less of an appetite for that. There's basically a smaller and narrower margin for doing that, especially when a lot of centers already have these types of technologies. So that's just something just to keep in mind. Relating to what Dr. Selby said here, Dr. Selby said, 96% is a great, but you're right, 1 in 20 may have a bad outcome. Luckily, at least in our series, the 4% were mildly lateral breaches. They were not medial breaches. But he's right. He's right. And I think that's a big point that Dr. Selby, I think, is highlighting. In several of these studies, there's a very high accuracy rate, a very, very low inaccuracy rate. But at least in one major study from a major US institution, and I always talk about this study, that one patient had significant lower extremity deficits. So I think that's one patient too many, in my opinion. I think we should be aiming for 99.99% safety, however you can achieve that and whatever tools you have for that. Good question about do robotic companies are they liable? Are robotic companies liable for misplaced screws or misplaced hardware? Well, that's a really good question. And I'm not a lawyer, so I don't know the answer to that. But I do know, being in this medical field for a while, right? Anybody could be liable for anything. But that's a great conversation to have. In my books as a surgeon, at the end of the day, the surgeon is in charge, and the liability is on the surgeon to ensure that they have done everything they could to optimize the successful outcome. To ensure a successful outcome for the patient, that lies in the hands of the surgeons and the surgery team. That's just a personal, non-legal opinion, if you will. So we do know that navigation and robotics increases the accuracy of pedicle screw insertion and placement. We also know that traditional freehand screws are safe overall. From a statistically significant perspective, yes, as Dr. Selby very nicely pointed out, that 1 or 2 patients may have a very bad outcome, and that's sometimes all it takes. So we don't need to rehash this, but again, going back to the revisions, this is also a very important study and important slides. Patients who have misplaced hardware, many of them, not all of them, but many of them end up needing to come back to the OR for a revision. So the revision rates are higher when you have malpositioned or misplaced instrumentation, even without neurological deficits. It could be unexplained pain. It could be a CAT scan or an X-ray that you get after surgery, and you say, wow, this was terrible. Again, this is not 10 years ago, 20 years ago, 30 years ago. This is now. And now we know that patients have, as they should, by the way, as they should, they have access to their imaging, their X-rays, their CT. They show it around. They go for multiple opinions. And basically, you just can't have patients going around with suboptimal instrumentation in their spine. It's not right. It's not fair to them. So we have to do everything we can to ensure the best possible placement of instrumentation in patients, in my opinion. Again, lower risk of surgical complications with robotics and navigation, but that's not because of less hematoma or less CSF leak or less wound infection. No, the lower risk of surgical complications has to do with the more proper and more accurate placement of instrumentation. We're obviously very excited here in our program. I'll just put a little plug in for our guys and gals and our research team, our clinical team. We're actively studying this topic a lot. We're doing both scoping reviews, systematic reviews, and we're also reviewing our own clinical series. But we really want to know, what is the true advantage? What are the future directions? Whether it's adult degenerative deformity, whether it's idiopathic scoliosis, whether it's minimally invasive spine surgery, what is the true what is the true benefit of these technologies? We got the ionizing radiation, right? There's less radiation to the surgeon and to the staff with CT guided navigation. There's also probably more accurate placement of instrumentation, but how about the clinical outcomes? And I think that's where I was having a discussion with our research fellow, Dr. Barbagli, who helped me put the slides together, by the way, a special thanks to him. We're far. We're from it. We're not there. We're not there to demonstrate clinical difference in long-term outcomes, but that's coming up next. And I think that will definitely be the next frontier, if you will. So these are studies that have been submitted already as abstracts, and the manuscripts are in preparation. But this is what we're looking at currently as the most comprehensive, up-to-date reviews. We know that the revision rates are lower with robotic technology, and we can get them even lower, specifically related to screw positioning and accurate placement of implants. So a lot of the robotics nowadays, a lot of the robotics and navigation systems are used in degenerative disease and deformity disease, and primarily in the lumbar spine. We've got a long way to go to trusting this technology in the high thoracic spine and even in the cervical spine. I know a lot of folks are doing great work out there in terms of robotics technology and navigation in the cervical spine. I used to do C1, C2 screws freehand. That's how I was trained. And I've used navigation, not robots, but I've used navigation a few times for that. And I have to admit, it does give you more options. It gives you more opportunities and more corridors to achieve the optimal fixation. So I do think there's a lot of work to be done in the thoracic spine, but especially high thoracic and cervical. We're also looking at idiopathic scoliosis. Idiopathic scoliosis is really, adolescent idiopathic scoliosis is interesting for a lot of reasons. Number one, obviously, the patients are younger, right? So these are young females, young males. The radiation is a very serious issue to them as well. So, when you're dealing with a child or a pediatric or an adolescent patient, we want to minimize the radiation to them as well. But on the other hand, a neurological deficit due to malpositioning of instrumentation is just that much more serious and has that much more consequences. So there's almost this dichotomy between, yes, we want to use less, perhaps, CT systems, if you will, or ionizing radiation technology, but it is that much more prudent and that much more essential that instrumentation in pediatric population is absolutely perfect. So that's an area that I think is really exciting for a lot of folks. Let me just look at the questions here. I'll try to answer some questions unless Dr. Goodwin or Selby want to help me here. If we already have an O-arm standard navigation, this is Dr. Driver asking, if we already have an O-arm or standard navigation, what are the advantages of getting a robot? Are there certain cases where a robot is superior in your view? I'm going to answer this in two ways. Number one, I'm early into my journey with robotics, so that's just a disclaimer. There are a lot of people here who have, years of experience, and I'd love for them to chime in, by the way. I'll tell you this from my initial experience with robotics technology. At the end of the day, it's navigation, right? At the end of the day, it's navigation. It's very much centered around accurately getting you to the right position so you can place your instrumentation efficiently and accurately. The one thing that I have found, at least with the platform that we're currently using, that I really like is that it's very steady, right? So I've been using navigation for 10 years now, right? So you take a drill guide and you have a navigated drill guide, and you're drilling the pedicle, you're using both hands. Maybe there's a little bit of toggling, a little bit of movement, but once you bring in that the robotics arm or the robotic arm technology, it's solid. So it frees up another hand, and you can just do a lot more. So I hate to say this, it's a really nice drill guide, if you will. And of course, you can also, in some systems, you can drill and put the screw right through that. But it is accurate, it is precise. I think the one thing that a lot of these technologies are missing, which will definitely change, is the automation. These robotic systems are really good at helping you place pedicle screws accurately, say at L3. You want to go to L4, you want to go to from L4 to L5. You know, as far as I know, there isn't one single button where you can press and it'll just take it right to the next level, unless it's close, unless it's within a few inches, you know, all of that they tell you. But the reality is there's a major manual component to it, which I think makes it a little bit inefficient. So, Dr. Driver, you know, my answer to you is, in my experience, I don't quite see yet a significant advantage of the robotic system over navigation, but I do see its potential. I do see its potential in terms of stability, automation from one level to the other, and I do think that's coming, and I think that's exciting. Dr. Faiz, I know we keep seeing these pictures of misplaced screws, but with the current technology, one hopes to leave the OR knowing that the hardware placement is perfect, and if not, then correct it. Yeah, I think you're right. I think you're right, and that's, you know, I used to tell folks this all the time, which is, especially my colleagues who really like you know, freehand, you know, placing screws freehand, which is great. I actually like that a lot. I just think navigation helps you do it more quickly. But that's what I say. I say, you know, before you leave the OR, you know, get a spin before you leave the OR. You don't have to worry about, you know, being anxious about potentially misplaced screw, or getting a CT the next day, or getting an X-ray later that you can't interpret. There's a lot of value of knowing that the instrumentation was perfect when the patient leaves the room. You have no control of, in general, CSF leaks, wound infection, hematomas. There's just certain things, you know, patients getting better or sometimes not getting better. Unfortunately, we can say whatever we want. We don't have much control over that. We really don't. What is the one thing we have control over as spine surgeons is when the patient leaves the room, we know where that hardware is. And for a lot of people, and to be honest with you, I'm one of them, that has a lot of value to me and to my patient. It's the one thing we have control over that I think we ought to leverage in 2023 modern spine surgery. Doctor, I'm going to answer a few questions, then I'll move forward a little bit. Dr. Leonardo Soto, in my preparation for my residency in neurosurgery, a robotic surgery intervention scoliosis, what would be the advantages and disadvantages? Yeah, great question. And I think, you know, the advantages in scoliosis surgery, especially with complex deformity and significant axial rotation, I think navigation is absolutely essential. It takes the guessing away, and it takes the trial and error away. You know, you place screws, and then you get an AP, and you're like, oh, this one looks a little bit off. Let's take it out. Let's tap. Let's feel again. Let's put the screw back in. It takes all of that away. I think there's significant advantage to using navigation technology for scoliosis. The robotics part, I think that's still TBA or TBD, to be determined. And that's really the theme here. It's, you know, if you think where navigation was 10 or 15 years ago, it's definitely gotten a lot better, more precise, more accurate, more reliable, more predictable. And I think robotics most likely in 10 to 15 years will be there as well. But it's not there yet, but it will be. But we got to get it there, right? Somebody has to do the hard work of actually doing the cases, learning the technology, working in partnership with engineers and with industry to make that technology more applicable and more optimized for patient care. One more question. With the screws, Trevor T, when the screws in general move consistently after post-op rehab physical therapy? No, typically the hardware does not shift. Hardware in the spine, when placed accurately, does not shift, barring of course, significant trauma. Great questions, guys. Really great questions from everyone. So what are the main drawbacks? We talked about all the advantages. We talked about all the great things that come with navigation, with robotics technology. What are the main drawbacks? The surgical workflow. It takes a lot. It takes a lot to reinvent the workflow in the OR. We're creatures of habit. We don't like anything to change. We like everybody, to be here and positioned here, and we really don't like a lot of changes. And here you are introducing a brand new type of technique or technology into the OR. Everybody's got to get used to it. everybody's going to get upset initially. Everybody's going to be like, why are we doing this? Why are you slowing us down? I swear, I wish I had this. I know I have this picture somewhere. So a long time ago, maybe about 3 or 4 years ago, somebody online on Twitter was talking about minimally invasive spine and this and that and the frustrations. And one person who identified him or herself as a scrub tech from I don't know what state they're from, but they identified themselves as a scrub tech, and literally they said, as a scrub tech in the OR, do everybody a favor and just do it open. And I just thought that was absolutely hilarious, because it's so true. It is so true that these techniques and technologies, especially for the staff around you, they don't see it the way you do, right? They're like, this is slowing us down. It's painful. It's annoying. So the workflow is a serious drawback. The cost is a real issue. But all technology, all new technologies is going to come at a price. That's not going to be cheap, but that is an issue. Registration software, screw planning software, and certainly the difficult cases and the very challenging situations. These are real drawbacks, and that's a drawback of really any technology. And I like that one, that especially the one where it says trauma patients, where you have potentially significant instability, like a fracture dislocation or a chance fracture or an ankh spondy fracture, right? You've got to be really careful, because where you place your reference array and what you do to the spine may be completely different. So you've just got to be very, very careful with that. A few more slides here. So where are we going with this? Well, I think there are several areas in which there is real potential for significant improvement. Number one, the software, registration software, the planning software. I think it definitely has gotten better over the last few years, but at least in my opinion, it still slows things down a little bit. It's not as intuitive. It's not as efficient as it could be. So I think on the hardware side, certainly that progress has been made, but on the software side, I think there's also significant room to grow there. One of my favorite things, which I talk about a lot, is the Nav Plus. Okay, great. We know we can place screws very quickly and readily and efficiently. What else is the robot going to help us do? Can it do a laminectomy? Can we, on the software planning, mark out what we want the robotic arm or the robot to do, and can it do the laminectomy for us safely without getting a CSF leak? If we can't do it today, there's no question that one day that will happen. It will. It's just a matter of time. But that's what we need. Meticulous end plate preparation, placing a cage through a very tight corridor in an MIS case. This is exactly what robots should do. This is exactly what robotic technology should be able to do. We're not there yet, but I do think we will be. Economically, of course, prices, the cost and the prices, they will go down with any enabling technology with time. Virtual and augmented reality, really exciting technology. I know somebody asked here about augmented reality. I think there has to be better integration. I worry when I see a lot of information out there on especially augmented reality. I hope that we're not creating a disconnect between CT-guided navigation, robotic platforms, and AR. I'd like to see that integrated a little bit better. I would hate to have the field go into these different directions. I think we should find a way to really merge and integrate these technologies. And finally, and this is the onus is on us as academicians and as clinicians in university-based settings, is we have to understand and learn how are we going to integrate this into teaching programs. The number one thing I get from a lot of my colleagues is, well, how are residents ever going to know how to put in screws, and what happens if the technology breaks down? And believe me, I'm very sensitive to that, and I understand that. And the guys and gals with me in the OR will attest to the fact that I always say, okay, find the landmark, show me how the screw would go in, figure out all that stuff, then look at the screen to fine tune things. So we have incorporated different ways to ensure that basic anatomic knowledge, foundational skills are right there. But the reality is, the field is moving in the direction of more automation and more enabling technology. And I very much, for better or for worse, I do think that at some point, a lot of the graduates will want to go to hospitals and want to join medical centers and practices that have these technologies. I think that's just a natural evolution of what we're witnessing today. And we also have an obligation to meet that demand. So we have an obligation to teach the foundations and the surgical skills, but we also have an obligation to meet the demand of the new surgeons and the young surgeons, if you will, who want to be at a 99% accuracy rate in terms of placement of screws. And I don't think anything is wrong with that. This is a little bit cliche, but I always tell folks it's not necessarily about us or our past, but it's about them and their future, right? And we have to also be cognizant about that. There's no point in saying, oh, well, we used to do it that way, and we always got it right. And that's not neurosurgery, and that's not orthopedic spine surgery, and that's not technology. So I'll wrap things up here, and maybe I'll take a few questions at the end. Robots are not going to do the surgery for you, right? Probably not, never. I hope they do more in the future. I hope we're able to get robotic technology to help us with the osteotomies, with the laminectomies, with the corpectomies, with the tumor biopsies in the spine. I know we have them for the brain, but not for the spine yet. But they're not there yet. I do think we will get there. If you're lost, you're going to be more lost with navigation and robotics. Navigation technology, robotics technology is not going to replace sound surgical skills and surgical foundation. It's just not. You may get lucky and it may help you in a case or two, or you may do some, you may put in a few screws. You may do a case and you say, oh boy, wow, without this technology, I don't think I could have done that. Good for you. That's not sustainable. It is not sustainable. You've got to be able to utilize this technology as an adjunct, not as a replacement for foundational skills. I do think the future is NAV plus, and NAV plus, in my opinion, is more than just pedicle screw placement. Decompression, osteotomies, rod contouring. Rod contouring is a big deal, right? Rod contouring, rod placement, sequential load sharing, and integrating the rod into a long deformity case. I mean, these are the hardest, sometimes the hardest part of the case. And this is where we really need robotics technology to shine. But I do think the future is very bright. I think there are a lot of opportunities in the future in this field, and certainly there are a lot more people out there who are far more advanced in this than I am. And I'm grateful to them. I'm grateful to a lot of our partners who have been doing the hard work and promoting this. I do think it's quite exciting. A couple of things here. Obviously, as a lot of you here, a lot of us here online are friends in the online world, and just a special shout out to the great team that we have. Phenomenal partners, spine fellows, clinical fellows, research fellows. We really are trying to here at University of Arizona to create a hub for technological and technical excellence. We're very proud of that. We're not embarrassed about that. We do want to be a hub for technology. And thank you to all the research fellows and the staff here with us. And of course, thank you to Giovanni, one of our superstar research fellows who helped me prepare these slides. So thanks very much. I appreciate everybody's time, and I will take a question or two if we have any. All right, I've stopped sharing my screen. Perfect. All right. Well, folks, thank you so much. I think we've gone through a lot here, and I hope everybody picked up a pearl or two. This is ongoing, and we will continue to learn more about this topic and hopefully share some upcoming publications and research with everyone. So thanks everybody for joining us today on Virtual Spine, and we will see everybody next Thursday. Have a great evening, everyone.